My name is Amy Lundstone. I'm a registered nurse and project manager with the California Bridge Program. So you are all being recorded. Today we're going to hear from Dr. Sky Lee and LaToya Mitchell, who will tell us how they did it, how they got their programs up and running in their sites. So again, for those of you calling in on your phone, you can press *6 to unmute or mute yourself. For those on the Zoom line, the mute button is in the bottom left corner, as well as the video. Please utilize the chat function for any questions. And Sky, take it away.
Hi, everybody. Thanks for joining us this morning. I'm going to share my screen. Okay. Feel free to use the chat box, ask questions. And today we're really just going to kind of give you a brief overview of who we are, how we got here, and what we have done. So neither LaToya and I have any disclosures. And so at California Bridge, our motto is treatment starts here, but really our motto should be treatment starts now. What we want to do is be able to provide patients and people with life-saving treatment whenever and wherever they show up, whether that's the hospital or the clinic, or if you're doing street outreach, we want to be able to start them with medications whenever they are ready. So we're just going to do a little bit of an audience poll. I'm going to have Amy pull up a poll for us to just get a sense of who everybody is on this call. We'll give it a few minutes until you can answer all the questions, because what we really want to do is be able to target this conversation series a little bit more towards the people on the call. Okay. Amy, I don't know if you can pull up like the results for it or not. Okay. So it seems like we have a lot of case managers and sons here, some administration people. I'm not sure what the other is. If you want to put in the chat box about your role, that would be fantastic. And it seems like the majority of people are in the emergency department. And I am unable to scroll down. Amy, can you read it out to me?
Yes, absolutely. So like you said, case management, patient navigators, everyone for the most part is in the emergency department. There's a mix, so 40% are not offering MAT in their hospital, and another 40% say MAT is happening sometimes, and 20% say it does happen often. And for the special focus topic, it's a little bit of everything. So Bupe Quick Start kind of takes the lead with acute pain, and Bupe after naloxone coming in as a tie for second.
Okay, great. So I think that's like a really nice mix, and we can focus a little bit more about how we got buprenorphine started in a lot of our hospitals. And then when LaToya jumps on, she can talk a little bit more about her role as a substance use navigator and how we were able to implement culture change in a lot of our hospitals. So with California Bridge, we started off with about 32 hospitals, and now we have expanded to over 50 hospitals throughout the state. And we are both in rural areas and urban areas. We are both academic centers and community-based centers. And so I've been really impressed and amazed by all of our hospitals and how far they've been able to come in such a short period of time. And really, like I said, to high quality treatment for substance use disorders in all hospital settings throughout the state. So I talk about this a lot because I think people get a little bit nervous about having an X waiver, and there's always a lot of questions about why do I even need to get an X waiver? And so in California, about 2% of the population has an opioid use disorder, so that's a little under 700,000 people. And if everybody in California with an opioid use disorder said, today is the day, today I want to stop using opioids and I want to get help, I want to get treatment, we would still be left with over 500,000 people who couldn't access treatment. And so the reason why is because we only have a limited number of methadone programs, and most of them are by and large located in more urban areas. And out of all prescribers in the state, we only have 3.2% that can prescribe buprenorphine. And so if I said, oh, I can't prescribe you insulin because I don't have a waiver, I don't think that would be acceptable to helping treat diabetes, right? And so I talk about this not only to encourage prescribers to get their waivers, but if you already have a waiver, to encourage your colleagues to get a waiver as well. And I want to spend a little bit of time talking about health disparities because it's pervasive throughout all of medicine. And particularly for addiction, non-white minorities are less likely to receive treatment. That can be for antidote therapy for an acute overdose, whether or not that's for Tylenol overdose or an opioid overdose. Non-white minorities are also much less likely to receive prescription for opioids for pain. And they are also less likely to receive a prescription for buprenorphine to help treat their OUD. And this is important because we are also seeing increasing rates of opioid mortality in the non-white minority population as well. And so I bring this up because I think it's important to be aware that this is happening so that we can start looking at our prescribing practices and start thinking about really evaluating, why am I offering this person buprenorphine, or why am I offering this person opioids for their acute pain episode and not this person? So I'm hoping that with awareness, we can start making practice changes to help eliminate these health disparities. And so at California Bridge, we're really trying to revolutionize our system of care. Not only are we providing rapid evidence-based treatment, but we're also changing the culture. So we're really trying to change the culture from one of stigma and blame to one of respect. And with that, we're really trying to work with our community partners to link people into care, because we can't do this alone. And so since we started collecting data in April of 2019, over 8,000 patients have been identified with having an opioid use disorder and offered treatment in all of our hospital sites. And out of that, 66% were started on medications for addiction treatment in the hospital. 62% accepted a referral to an outpatient treatment provider for follow-up care, and 41% completed a follow-up visit with an outpatient provider. And this is huge. These are people that otherwise would have been lost in the system, or they would never have even engaged in re-engaging in care. Because our goal is not only to start treatment in the acute care setting, but also link them with a primary care setting so they can reestablish and engage in care. Because once you start treating their opioid use disorder, you can address other things too, such as heart disease and diabetes and high blood pressure. And so for every 10 patients with OUD, 7 have received treatment and 4 have engaged in follow-up care. So this works. And so here's our program data, is that you can see that as we've started, we had really nice increases in people identified with OUD, people who received buprenorphine, people who completed follow-up visits, and then you see COVID. So that drop is when COVID happened, and we saw a decrease in visits in the emergency department and decreased follow-up visits because it wasn't available. People were afraid to come in. And so I think this really highlights the importance of, yes, we are in a COVID pandemic, but we really can't ignore or forget about the opioid epidemic as well, because our patients need this care and treatment, and we are anecdotally hearing increases in use, whether or not for all substances really, including alcohol, and we are seeing increases in overdoses as well, anecdotally. And so now is a really important time to not forget about our patients. So I'm actually going to skip through some of these slides in hopes that I think LaToya is held up a little bit.
Okay, we actually,
Is she
LaToya
on?
is here. Yeah,
Okay.
LaToya, I'm gonna go ahead and unmute you, okay?
And then LaToya, I'm going to mute myself, and then you can tell me when you want me to click through the slides.
Okay. Can you guys hear me?
Yes, perfect. Thank you, LaToya. Thank you for joining us.
Okay, sorry about that, you guys. I was with a patient. All right, so navigator, advocate, coordinator, counselor. There's many titles for what we do as a substance use navigator, but with one primary goal of exhibiting compassion and understanding to help vulnerable people in our community connect to the treatment they need, want, and deserve, while fostering a harm reduction approach and ensuring access to life-saving naloxone. Next slide, please. With the Bridge program, there are 4 major components to the process. So ideally, we strive for a warm handoff where the patient comes to the ED, the patient with the substance use disorder is identified, the son communicates with the patient and then consults with the provider to start treatment, and then the son helps guide the patient through the next steps of ongoing care. These next steps could vary. Next steps could be referral to outpatient treatment, referral to a detox program or residential treatment, so on and so forth. Next steps could also include that patient having a medical condition that requires admission to inpatient treatment. So going a little bit more into detail about the conversation between the patient and myself, we'll go to the next slide, which is the son encounter. So with the son encounter, I found it much more effective to start with introducing myself and my title, genuinely asking how the patient is doing, explain the purpose of the conversation, and then thoroughly explain the patient's confidentiality rate. That usually helps to build the rapport and allow them to feel comfortable and safe opening up. I make sure to educate the patient on all of their treatment options, what to expect with treatment, especially if they've never been in treatment before. And I write down all the referral information on paper along with my contact info. I also explain to the patient that after this encounter, I am now part of their support system and they can feel free to reach out to me in the future. You know, maybe their treatment needs have changed. I can help them navigate through that process and provide referrals to other treatment options. And sometimes they just like to check in, and I can do that too. Next slide, please. So when a patient's not ready to stop using, I always make sure to thank them for their time and provide the patient with education on ways to reduce the harms associated with substance use. You know, things like abscesses, infectious disease, and overdose. I also provide information on our local needle exchanges. I'm proud to say we now have 2 in Kern County, as opposed to a year ago, there were none. And we always make sure to discharge with naloxone. Next slide, please. I've been asked many, many times if what I do is just in the ED. And my response to this is, if the patient comes to the ED, yes, they're mine. But if any patient in the hospital needs help with substance use treatment, I'm a hospital employee, not just an emergency department employee. So I'm available to help all over the hospital, wherever they go. I will, you know, follow their care and I'll help them everywhere they are. But I not only help with buprenorphine starts in the ED, I communicate.
All clear. Grade 4E, all clear.
My apologies for the loudspeaker, guys. So I communicate with the hospitalist and intensivist about continuing medication inpatient. I make sure to also communicate that to the nurse that's taking over care as well. if the patient was not able to start BUP in the ED, which is usually because they used too recently, I work with the inpatient care team to coordinate a BUP start at a safe time. So what that means is that the inpatient doctor, the hospitalist, intensivist will put in orders ahead of time, but they schedule it for 12 hours after the last opiate or opioid use to avoid any precipitated withdrawal. Whenever I encounter a hospitalist who is not very familiar with buprenorphine or the Bridge program, I just ask for whatever their best email address is, and I offer to send them information that will give them a better idea about things, along with the algorithm. And normally after that, they're really receptive and are on board with BUP start. Sometimes a patient makes it to inpatient and I'm not consulted until after the patient is threatening to leave AMA because they're sick. So medications with opioid use disorder is a great incentive for the patient to stay until medically cleared. And every time this has been the case, the hospitalist is 100% on board with giving orders for a BUP start or even a methadone start. I keep track of the patient while they're admitted and what their discharge plan is. This way I can schedule their outpatient MAT appointment. I can help facilitate any prescription that's needed, since not all of our doctors here have an X waiver. So I usually have to work with whatever doctor does have an X waiver that's available to write a prescription. And then I also help with the process concerning skilled nursing facilities. So in Kern County, and I'm not sure if other counties are the same, but our SNFs will take a patient who is on methadone treatment and they provide the methadone, but they don't do the same for buprenorphine or Suboxone. So what we end up having to do is submit the prescription to the pharmacy ahead of time, have it delivered to the hospital prior to discharge, and then we confirm with the skilled nursing facility that the patient has the medication. That way it doesn't become a bad experience for the patient. They're not having to go into withdrawals all over again, and they're able to get all of the care that they need. I also help with patients who come to the hospital who are already on medications for opioid use disorder like methadone or Suboxone. I help in this way by taking care of the sometimes tedious paperwork of dose verification. Me taking over this part allows the nurses to focus on their patient-related tasks. And the nurses here really love that. It's part of my job, so I say, why not, Next slide, please. So part of what helps me be a really impactful son at Bakersfield Memorial is the support team. Our support team consists of a fantastic Bridge champion who is on this Zoom call, which is Sky. And then I have about 8 different internal leaders here at the hospital. To name a few are like the nursing director, director of pharmacy, ED manager, and 2 of the ED doctors. And without this support team, I wouldn't be able to do what I do here. Next slide, please. I realized very early on that our nurses are in a really unique position to help further my efforts because they meet with every patient. They're the ones who initially ask about substance use, and they're also the ones who can ask whether or not that patient wants help connecting to treatment. So it was really important for me to make sure that I educated as many nurses as I could. Now I'm able to hold trainings for the nurses, especially the newly graduated ones who get to step foot in any hospital. I also hold trainings for new hires, and I get like a time slot for the annual nurse competencies. But one of the most important parts of nurse education is walking around. So I walk around the ED so I can talk to any new travelers that have come on board. And I also walk around the inpatient floors to talk to any of those travelers because they're only here for, you know, a few weeks, and then we get new people in again. And so anytime I have an interaction with a nurse or any hospital staff, I take that as an opportunity to share who I am and what I do to help our patients. Next slide, please. Lastly is community outreach. It's a really big part of what I do because, as Sky mentioned earlier, we could not do this alone. We need to have partners in the community. I needed to have, you know, landing spots for our patients when we did a referral. So not only did I reach out to treatment centers in Kern County, but I made it a goal to really understand from the patient's perspective what treatment there would look like. It's scary to make these life-altering changes, and sometimes it gives patient peace of mind to have an idea of what to expect. I also worked with those treatment centers to streamline the process and get referrals in as quickly as possible. I worked with the pharmacies to find out who keeps the medication in stock and what doses. And then as a hospital team, we worked with the EMS to make sure all instilled drug overdoses are brought to our ED. We used to hear EMS comments that families would ask, you know, where can they get help? And they felt frustrated that there wasn't anything they could give the families as a starting point. Well, now Bakersfield Memorial ED is that starting point. Now our hospital is that starting point. And, you know, myself being the substance use navigator, I'm ready and I'm available to help connect those patients to ongoing treatment. What we do for our patients and our community is really a whole team effort. Depending on who you ask, some of our staff here might say, you know, they couldn't have done it without the sun. But I don't give myself all of that credit because it takes all of us. It's truly a whole team effort. Next slide. And so with this, you see a lot of our team throughout California.
Okay, so the next section is just going to be a little bit about cases, but I'm not going to spend too much time on the details. I really just want to highlight that this is easy, this is not hard, and that it's completely doable in your hospital or department. And so if people have more detailed questions regarding medications, you can always utilize the chat box and then we'll get to them, or you can always feel free to reach out to me afterwards as well. So this one is, the first case is really just a very simple 28-year-old gentleman. He came in to the emergency department and he's in withdrawal from heroin. So what do you do? How do you even start this? So before, we would get lab testing, we would get blood draws, we would get urine drug testing. We would have to sit down and figure out, does this person have does he meet the criteria for an opioid use disorder? Then we would also have to take extra time and figure out, you know, is he in enough withdrawal? And we would have to calculate a CAL scores, which is very similar to a CWA for alcohol withdrawal. And so it was a lot of steps and it was a little bit complicated. And what we found was that it just didn't work. Patients didn't like it. Oftentimes they had bad experiences with blood draws. Urine drug screens are stigmatizing, and also waiting for labs takes a long time. And people are really uncomfortable when they are in withdrawal. Even though opioid withdrawal by itself without other comorbidities isn't fatal, it's incredibly uncomfortable, and many people will do anything they can to prevent that from happening. And so this extra time and delay in care is actually very detrimental to the patient experience and to actually getting people onto treatment. So it took too long, it's too complicated, providers didn't like it, the patients didn't like it, it just didn't work. So we changed it. We kind of cut out some of the extra fat and we created a lean butte model. where we gave patients reassurance, okay, we will treat your withdrawal, we will get you started on treatment, and we will do it quickly. And we also have this idea of opt-out BUP. We really, the reason why we're trying to change the culture of the hospital involving everybody and ancillary staff is not only to help with the patient experience, which is so important, but also to encourage people to self-disclose. We don't want to re-traumatize, and we don't want to ask people to reveal a stigmatizing condition if we can't actually do anything about it, right? And so we want people to feel comfortable enough to come in and say, hey, I need help with this, and to know that we will treat them with the respect that they deserve and with the speed of treatment that they deserve as well. So this is a little blurry. It can look a little busy, but this is our quick start algorithm. It can look complicated, but all the stuff on the right is just extra info. It's just like if you want to know more. Our actual algorithm is what's on the left, and it's actually pretty simple, and I'm going to go through it a little bit quickly, but I'm going to go through it right now. So say someone's in uncomplicated opioid withdrawal. Great. We give them 8 milligrams of BUP. If they're not in withdrawal, then we would just stop our BUP when they are in withdrawal. And how do we know? Before I mentioned that we got rid of our CALS, or clinical opioid withdrawal scale. And so we know they're in withdrawal because we just ask them. We trust the patients and we say, hey, are you feeling like you're in opioid withdrawal? And they will say yes or no. And if they say yes, we also look for one objective sign of withdrawal. So meiosis or piloerection or sweating or diarrhea. And once we have that, then we can start. We have found that you don't really need to wait for a CAL score of a certain number in order to start. As long as patients say that they are in it and they want to start, you can start them. We also give 8 milligrams of buprenorphine. I know some places give lower doses like 2 milligrams or 4 milligrams, but what we found was that just really delayed the resolution of their withdrawal. With 4 or 2 milligrams, it would incompletely treat their withdrawal. People would still feel bad. You would have to wait, and then they'd have to wait for people to get the second dose of the buprenorphine, and it just wasn't quick enough. And for the majority of people, if it's uncomplicated, short-acting opioid withdrawal, you can give them 8, and it works fine for the majority of people. So say you give them 8 milligrams, you wait about an hour, the peak should be within 15 minutes. And then you ask them, hey, do you feel better? We'll get to the no section after this slide, but if they say, yes, I feel a lot better, then you can give them the second dose. If they are if they're going to be admitted for something else, you can give them a second dose of like another 8 milligrams, and then the next day they should be out of withdrawal. So you're really titrating from there to cravings. And so you start the next day with 16 milligrams, and then you titrate, you ask them how they're feeling about their cravings, and then you titrate up. If you're in the emergency department and they come in, they feel better after the 8 milligrams of BUP and they're not going to be admitted, you can give another second dose of anywhere from 8 to 24 milligrams. You can give a little bit of a higher second dose if you want to do what's called a loading dose. And the reason to do that is because it will continue the effects for a longer period of time. So say someone comes in on Friday, they can't get an appointment until Monday, and no one in the ED has a waiver to write them a prescription, or say the pharmacy is closed, then you can load them with a total of 32 milligrams, and that will carry them through the weekend where they won't go into withdrawal, and it will have less cravings to prevent use until they can get to their clinic appointment. And I had this say that this works both from ED providers and also from clinic providers as well. And in general, if you're treating someone with BUP for OUD, they need at least 16 milligrams of BUP per day, whether it's split dosing or not, because lower doses have shown to have decreased retention. So I tend to maintain people somewhere around 16 to 32 milligrams a day. So let's go back a little bit and let's say, okay, so you gave him an initial 8 milligrams of bupe, and then you check in on them and they're like, I don't feel better. This is a nice time to pause, step back, and think, okay, what else could be going on? It's a time to reevaluate your differential, especially because people might think that they're in withdrawal, but really they might be in DKA, they might be septic, they might have the flu, or there could be a bunch of other underlying illnesses that could mimic withdrawal. And so if someone gets 8 milligrams and they don't feel better at all, not even a little bit, then I try and think of like something else is going on. If they got less, if they got only 2 milligrams, then it could be that they have this incompletely treated withdrawal that we had talked about before, and their symptoms will improve if you give them more buprenorphine. Sometimes people have like a little bit of nausea, headache, and these are just kind of just a bupe side effects, and you can just give them supportive medications for that. The big thing that people are afraid of is this idea of precipitated withdrawal. That usually tends to happen mostly with methadone, or if people have been on something long-acting recently. And with that, if you give them more bupe, if they say they took methadone yesterday and you gave them 8 milligrams and precipitated withdrawal, generally they're not going to feel better if you throw on more and more buprenorphine. But it is self-resolving, and so you can just take that time. If you really think this is precipitated withdrawal, you can just stop the bupe, stop what you're doing. You can give them full agonists if you really need to. You can give them supportive medications, and you can restart later. What our goal is to really make sure that patients have a good experience with the hospital. And even if they feel really terrible with precipitated withdrawal, some patients have come back and said, okay, yeah, you know, this wasn't your fault, this wasn't the medication, like I'll come back later when I am ready, and or when like the methadone has come out of their system. I think I also have a slide in here about fentanyl as well, and I'll get to that as well. So when I discharge someone, you document that they're in opioid withdrawal or they have an OUD as a diagnosis. If you don't have a waiver, you can give them a loading dose like we had talked about. And if you're in the emergency department and you're writing a prescription for bupe, if it's less than a 7-day prescription, you do not have to check cures. But to write a prescription for buprenorphine, you will need your X waiver. And for everybody, I give a naloxone kit. If you can give it in hand, that's even better, because oftentimes a lot of the prescriptions aren't filled. I also give naloxone to people who use methamphetamines, cocaine, any illicit substances, because of the high prevalence of illicit fentanyl within our drug supply currently. So I give naloxone to everybody. I also talk about it in a way of like a fire extinguisher or sprinklers. I say, hey, you know, I don't think our hospital is going to ever catch on fire, but if we do have one, I'm really happy that we have fire doors, we have a fire plan, we have fire extinguishers. It's just there as an emergency. And the other thing that is really helpful sometimes in convincing people to keep an naloxone on them is that they can save somebody else's life. They can be a hero. If they see their friend or family member or loved one down and they think this might be due to an opioid overdose, they can save somebody's life. I actually don't know if I have a fentanyl slide in here, so I'm just going to talk really quickly about fentanyl, and then maybe we can open it up to questions, because I think a lot of people here are substance use navigators, and if you have more medication questions, we can talk about that as well. There are a little bit of conflicting data on fentanyl. We are learning more and more about it. There is some controversy and confusion and people saying that naloxone doesn't work for fentanyl, but it actually does work for fentanyl. So I don't want people to say, oh, this is probably fentanyl, I'm not going to give naloxone, especially on the streets. But there are there is an increased mortality with illicit fentanyl, and some of that might be for a variety of reasons. It might be that there's more fentanyl loaded on the mu receptors, or maybe you need a second dose of the naloxone and there wasn't enough waiting period in between the sprays. Or it could also be there's a thing called wooden chest syndrome that can happen with fentanyl. It's described more in the anesthesia literature. But what happens is you can get laryngeal spasms and you can get chest wall rigidity, so it's really difficult to breathe. And so you might have a little bit more significant respiratory depression with illicit fentanyl, but we're still learning and gathering more data about all of this. So I still recommend giving naloxone and using naloxone even if you suspect that this is a fentanyl overdose, maybe even especially if this is a fentanyl overdose. And in regards to starting buprenorphine with someone who has known to be using illicit fentanyl, every once in a while, it can also precipitate withdrawal. And the idea is because maybe if people are using it for a long time or higher doses, it is lipophilic and can stay in the fat stores. So if someone is like saying, oh no, I have only been taking oxy that I've been buying from the street, I don't use fentanyl, but if they precipitate withdrawal, it might just be because there is fentanyl mixed into it that they didn't know about. So there is more studies coming out. There isn't really a lot of consensus yet, but I wanted to acknowledge it because it is definitely that we are seeing more and more of. But I want to pause here. Amy, can you read out if there's any questions on the chat box? And LaToya, do you have any other thoughts or comments that you wanted to add?
There are a few questions, but I'll give LaToya a moment to weigh in here.
I don't really have any other thoughts or comments to weigh in, but I did see a question about inpatient treatment that I would like to answer.
Perfect. So Sky, there's a few questions, and I think what makes sense is there's a question regarding starting buprenorphine after treated with Narcan following an overdose. So maybe we'll work backwards through the content that you've shared.
Yeah, let's go through that. I'm actually going to go through some of the slides to find the slide on oh, here's the slide about fentanyl. So we can have this up on the website so that people can scroll through some of these slides if they want to.
We can also send the slide deck out in an email afterwards, so everyone will have access to this deck.
Mm-hmm. Yeah, that would be great. And so, yes, we definitely recommend if someone comes in with an opioid overdose and you've reversed them with naloxone, these are some of our more vulnerable patients, right? These are patients who are at higher risk of increase in mortality because they've already had a near fatal opioid overdose. And so it just makes sense that these are the people that you should be starting buprenorphine on, right? And so this algorithm right here is how we start buprenorphine after we reverse an opioid overdose with naloxone. Right now, we are only really recommending it if it's a more straightforward case and if they are well. Obviously, if they're altered or they don't want to be on buprenorphine, you can't start it. And then if we suspect any other like intoxicants or sedatives and we recommend not doing it, or if they've recently used methadone, we recommend not doing it. And if they are critically ill, then this can probably wait. But if they were using heroin or another short-acting opioid, came into the ED, got reversed, or was reversed by EMS, and they come in and they want to start buprenorphine, as long as they're not sedated or altered and they meet all these criteria, then you can start it. In this one, we have increased our starting dose to 16 milligrams of bup. You can do it divided. You can do 8 if you want. You can do 16 if you want to. And we have been doing this in several of our emergency departments, including Bakersfield, which is where LaToya works. And we have had some pretty good successes with this. And it is really nice to be able to provide treatment for someone and with such a life-saving medication. Because I don't think I mentioned this, but when you compare buprenorphine, buprenorphine has a significantly, if you start people on buprenorphine, it will significantly reduce their all-cause mortality. Some studies say 3 times, some studies say 7 times. Like, it's a little bit variable on like how much, but it's pretty incredible. And I can't think of another medication that does this. I mean, we put everybody on a statin, but statins don't reduce all-cause mortality the way that buprenorphine does. And so it's just another reason to start it.
Great, thank you so much, Sky. So this next question I'm going to direct to LaToya. Sky, please feel free to weigh in if you feel you have a little extra to add. There's a question that came in from Amber about what disciplines are checking in with the patient about their withdrawal symptoms. So is that nurses, SUNS, any other disciplines in the patient treatment area? LaToya, can you speak to that?
That's a really good question. Yeah, absolutely. That's a really good question, and I would say both, because just like I said earlier, it's a whole team effort. I'm not a nurse and I'm not a doctor, but I make sure to check in with the patient so that I'm aware of where they're at and how they're feeling. But also, we do it as a team with the nurse and the treating provider, so that we're all on the same page of whether or not this person needs a secondary dose, a higher dose, and all of that stuff. And then especially if the buprenorphine doesn't seem to be helping, then we have to, just like the algorithm shows, stop and see if there's something else going on. If just I was checking in with those symptoms, I wouldn't be able to assess that. So we do it collectively. We both do, myself and the nurses check in and see how they are after that 1 hour mark, dispense the second dose. Well, usually the LVN dispenses the second dose. And then that's when I start working with them on all the other parts, like referral, and wherever else their needs are going to take them.
Yeah, and I just want to add, to really just trust the patient, like, you can ask them and they will tell you how they are feeling and if the medication is working. But if you have any concerns, or if you're not really sure, even though you don't need to utilize a CALS or a clinical opioid withdrawal scale, it can be a really helpful tool sometimes. And so while it's not necessary to start in most cases, and while I don't really recommend using it serially, if you're in a little bit of a bind, you're not entirely sure, I think it's a really helpful tool.
Fantastic. Thank you so much for that. This next question, I think, is also directed towards LaToya. There was a question that came in from Joe, one of our sons, regarding if the buprenorphine would follow a patient to skilled nursing upon discharge. You had mentioned that methadone sometimes might be covered, but you would not be covered. But would the patient still be able to take that medication, and what other considerations should be factored in when being transferred to skilled nursing?
So that's one specific medication that we have to treat a little bit different. So normally with skilled nursing, the case manager works with a specific pharmacy that delivers all of the medications to that skilled nursing facility before the patient gets there. And so they have to go through all these processes to, make sure that they have a list of the medications and what the dosage is, how often, all that good stuff. They don't do that with buprenorphine. So, and we had to find that out the hard way, unfortunately. So what we do now, which is a much easier route for us, is we treat it separate. So the case manager will fax the pharmacy that they normally use for SNF all the other medications that the patient will be continuing on. Usually it's IV antibiotics and stuff like that. And then separately, I'll work with an ex-waivered provider to fax over the buprenorphine prescription to the pharmacy that we normally use right around the corner from our hospital that always keeps bupe in stock. And they deliver it here to the hospital with us, and that actually goes in the patient's possession. So the patient hangs on to that medication, not the nurses at the skilled nursing facility, and the patient will dose themselves each day, you know, however it's prescribed, versus the other medications. But even though it's separate, we still make sure that that part is taken care of before they leave the hospital. I hope that answered the question.
Thank you. Looks like Jill says thank you on that as well. And there was one more question that Jill had earlier regarding how to get inpatient bupe started if they were already started on opioid medication. So Skye, could you address the co-concurrent prescribing or any considerations there?
Sure. I think it really kind of just depends on why they were prescribed the full opioid agonists like Merco or oxycodone. And you could do it similarly in that if they say they've been in the hospital for a long time and they initially had a surgery or something else where they needed full agonists and then they stopped and no longer need it. You can, if they've only been on the short acting, you can always wait the 12 hours. Say they get their last dose at nighttime, and then they can start their bupe in the morning if they wanted to. It's also really nice. We have a thing on acute pain and bupe as well, but if someone comes in the ED and they're noting a little bit of an acute pain episode, you can always start buprenorphine for pain as well, because it works for both pain and for opioid use disorder. I'm going to scroll down a little bit. So these are our acute pain management for patients who are already on buprenorphine. It's a little bit different if they haven't been on buprenorphine, started on full agonist and then transitioning. There's a couple of different methods and ways to do that. If they're leaving the hospital right away, you can always do a buprenorphine home start. We have a worksheet available on our website, bridgetotreatment.org, under resources, where you can hand it to patients and they can just start it at home when they feel like they're in withdrawal. It's fairly uncomplicated for most people, particularly if they have already tried buprenorphine before or they know what withdrawal feels like. And the reason why we have two algorithms here is because one of them is a little bit more directed towards the emergency department and critical care, and it's got some of the dosing for things that we don't tend to use so much on the med-surg floor, such as we don't use ketamine or magnesium or IV lidocaine on the med-surg floors, but you can in critical care and in the emergency department. So that's why they're a little bit different. But you can always do a bunch of other medications as well to help with their acute pain episode. And we've listed the different options below. Oh, also, if you do have a clinical question about a specific case that seems a little bit more complicated, you can always call the California Substance Use Line. Their number is listed on the bottom of all of our algorithms. It's 24/7. It's for clinicians to call for any sort of clinical case and get expert advice and opinions. In California, it's 24/7. If you're calling outside of California, somebody will answer during business hours, Monday through Friday. But if it's outside of that time, you can leave a voicemail and generally they're able to get back to you the next day.
Fantastic. Thank you, Skye. There was a question for LaToya about working with patients whose insurance created delay in authorization for bupe or require additional referral for MAT. The question wants to know sort of how to navigate that, and as a substance use navigator, are there specific approaches that are more successful?
So I'll address the referral part first. You know, I used to be a clinic manager at a medication-assisted treatment center. So that process I already know very well. And typically we're able to get the referral authorization next day for MAT treatment, if not the same day, depending on what time of day it is. So when I have somebody that has, you know, private insurance, especially, those are usually the ones that require a referral. That's the process that I'll call the MAT clinic first, let them know what the insurance is, obviously after getting, you know, written consent from the patient. I send them the patient's information, the ID, the insurance card. They work on that part. And we make sure that we discharge the patient with a prescription to hold them over while they wait on that authorization and get an appointment at the MAT clinic. Now, if the insurance requires some sort of authorization to fill the prescription of the buprenorphine, that's where a loading dose comes in. So we have had that. It's very rare. Normally they're able to authorize it right away. But we have had a couple of cases in the past where patients come back to the hospital right after leaving the pharmacy saying, you know, I can't pick this up yet. They're saying it's not available. I have to wait on, you know, XYZ. Then we give them a loading dose. That way, at least they have a few days to work with until they can pick up that prescription.
Thank you, LaToya. There was another question regarding, you had made a comment about how you were employed by the hospital and you support both the ED and inpatient setting. There was a question regarding where substance use navigators are employed under with their specific departments or units. And I think that honestly, this varies from site to site. So LaToya, can you speak a little bit to your site? And Sky, if you have any other sites to reference about other departments that the substance use navigator is employed in?
Yeah, so I do know that some substance use navigators are, you know, primarily employed with, like, say, the grant, or are specifically assigned to the emergency department. I am specifically assigned to the emergency department. I am also hired on by Dignity Health. But I meant what I said about that to be more in terms of the emergency department is part of a whole. It's not a whole itself, so it's part of the hospital. And whether I'm assigned to the emergency department or not, I still feel like my obligation is to the whole hospital. And one of the things that when I first started, I really got that question a lot, like, is it just in the ED? And honestly, the way I saw things, especially as the patients who were coming in through the ED were getting admitted and going to inpatient, I thought to myself, well, nobody said I couldn't. So I just followed them wherever they were in the hospital. And I followed their care, and I, you know, made sure that I was there throughout the whole process. And that was kind of the basis I went off of at first. It was, you know, this is new. We're kind of paving the way and setting those parameters. And since nobody technically said, LaToya, you have to be in the ED and only in the ED, you don't leave the ED, you only help patients in the ED, nobody ever said that to me. So in my mind, it was like, well, this is my job and I'm here to help patients, so I'm going to help them wherever they go.
Yeah, and that is similar. So I'm at UC Davis, and that is similar for our substance use navigators as well. Although they're primarily located in the ED, they see patients on the inpatient floors as well when we consult them. Some of my other sites, the substance use navigator is housed under case management or social work, and that's who their supervisors are. But each hospital is a little bit different, and the funding for the substance use navigator is a little bit different based on the individual hospital.
And some hospitals have chosen to have their substance use navigators in social work or in case management, sort of whoever has the bandwidth or the way the individual structure varies that makes it most effective. So we are about 2 minutes left in our designated time today. I wanted to invite any additional questions to please chime in. And Sky, I know you've got a couple more slide decks. Anything else slides you wanted to touch on before we wrap this up?
No, yeah, these are just my take-home points. We're already seeing people in the hospital with substance use disorders, and we just need to treat it like we would treat any other chronic medical illness. There doesn't really need to be a delay in treatment because of X, Y, and Z. Those are all just different barriers that we don't need in our lives or in our patients' lives. Buprenorphine and methadone, it saves lives. If you want to start it, it's very straightforward. It's within your scope of practice. It is really great to have a son available because they're really wonderful leaders and they can help connect with your community. But if your hospital does not have a substance use navigator, you can still do this. We have places where, and I know of places where they didn't have a son and they're still able to do this work. So really the point is to just treat it. It works, it's easy, you can do it.
Fantastic. Thank you so much,
Agree
Sky.
with that. Sorry to interrupt. There's another hospital here in Bakersfield that doesn't have a son, but they still went ahead and got a lot of their doctors ex-waivered, and they do buprenorphine starts, and they distribute naloxone from their ED. And I work with them. I communicate with one of the doctors there probably at least every couple of weeks. But what I did is I just shared my resources, and the doctor shared it with their case managers and social workers so that they can still refer patients. And sometimes when they have like a little bit of a tougher situation with the patient, they'll contact me directly after getting consent, and then I just kind of take over from there with that patient, even though they're not, even here at Bakersfield Memorial. That hospital is still doing very well with implementing the same idea as the Bridge program and without a son.
Fantastic. Thank you so much, LaToya. Thank you, Sky. A big thanks to everybody who joined and had questions for us. We really appreciate the time you took to show up and listen to this incredibly informative moments. As I mentioned in the chat, we will be sending out the slide deck later this week, as well as additional resources. Please reach out if you have any questions. We are here for you, and hope you have a wonderful rest of your week. Thank you.